All right, let's dive into acute decompensated heart failure, or ADHF for short.
Sounds good.
It's a condition we see all the time in the hospital.
Oh, yeah, definitely.
And we're going to be looking at some excerpts from McGraw-Hill's NAPLEX review guide to make sure you know all the key things to know to be a great pharmacist to handle these really tough situations.
Yeah, absolutely. I mean, it's more than just, knowing the signs and symptoms. You really got to understand what's going on hemodynamically, how the body is trying to compensate, and all the things that we can do as pharmacists to help these patients.
Yeah, this is not just some theoretical exercise, right?
Sure.
This is like, we want to give you the tools to be a confident practitioner.
Yeah.
So let's start with the basics, right?
Okay.
What is ADHF? What makes it such a critical topic?
So imagine you have a patient who has heart failure already, right?
Okay.
Their heart's not working so great.
Yeah.
And then all of a sudden, something happens.
Yeah.
Maybe they get an infection, or maybe they weren't so good about taking their medicine.
Yeah.
Or even something as simple as taking Advil or Motrin could tip them over the edge.
Yeah, wow.
And that's essentially what ADHF is, right? It's this rapid worsening of their heart function. And often, they go into stage D heart failure, which is, really the most advanced stage where the heart is really struggling to keep up.
Got it. So their heart's in a tough spot, and then something comes and pushes it over the edge.
Yeah.
And we're talking about people that are having symptoms even at rest.
Yeah.
So their daily life is being really significantly impacted.
NYHA class 3.
Exactly, yeah. No wonder these people end up in the hospital. But before we jump into treatment, can you walk me through what's going on in the body?
Sure.
It sounds like there's all these different things happening.
Yeah, it's a tug of war physiologically.
Okay.
So the body, like it always does, tries to compensate, right? So the sympathetic nervous system kicks in, that fight or flight response.
Yeah.
And the RAS system, the renin-angiotensin-aldosterone system, gets activated as well.
Okay.
And they both have a goal of trying to maintain cardiac output, trying to get that blood to the vital organs.
Okay, so their goal is to keep the patient alive.
Exactly.
But knowing the human body, I'm assuming there's some unintended consequences to this.
Well, you always got to watch out for the double-edged sword, right?
Yeah, okay.
So on one hand, these systems are trying to help.
Yeah.
But on the other hand, they're actually making the problem worse.
How so?
So the sympathetic nervous system, for example, it's going to cause vasoconstriction. Those blood vessels clamp down.
Okay.
And that increases afterload, which is the resistance that the heart has to pump against.
So it's like trying to push water through a narrower pipe.
Yeah, a really good analogy.
It takes more force, right?
And the heart is already weak, right?
Yeah, makes sense.
And then you have the RAAS system, which is all about holding on to fluid, retaining fluid.
Okay.
And that increases preload, which is the amount of blood returning to the heart.
Okay.
It's like, imagine trying to fill up a bathtub that's already overflowing.
Oh.
And you keep adding more water. That's what's happening to the heart.
So the heart is already struggling, and then it gets even more blood.
More volume, more work to do.
Oh, man. This is where BNP comes in, right?
Yeah, you remember BNP.
Like a little signal from the heart.
Yeah, so BNP, or brain natriuretic peptide, this is a key biomarker.
Okay.
And it gets released by the heart when the heart's getting stretched too much, like when it's volume overloaded.
Okay.
It's like the heart saying, hey, things aren't going so well down here.
So this is a cry for help. Does it actually, do anything?
It tries to help.
Okay.
So BNP has some good effects. It tries to counteract those bad things we talked about, right? It'll try to cause some vasodilation, open up those blood vessels, and it tries to get rid of some of that excess fluid.
So it's like working against the RAS system.
Yeah, it's trying to fight back.
Right.
But the problem is it's often not enough.
Yeah.
It's like trying to bail out a sinking boat with a teaspoon.
Oh, man. So you've got this interplay between these different things, all this physiology.
It's complex.
How does this manifest in the patient, when you're seeing them?
Right.
What are the red flags that make you think, uh-oh, this is ADHF?
Well, one of the biggest ones is dyspnea.
Dyspnea. Okay.
Difficulty breathing, shortness of breath.
Yeah.
And especially if it's new or worse than their usual.
Yeah.
But ADHF can be sneaky. It doesn't always look the same in every patient.
Right. The guide mentioned all these different profiles, warm and wet, cold and wet.
Yeah, those are important to know.
Can you break that down?
So think of it like this. We're categorizing them based on their perfusion status, so how well their blood's flowing,
Okay.
and how much fluid overload they have.
Okay.
So the wet part, That refers to signs of fluid buildup, like edema, swelling in the legs or ankles, even in the lungs.
Okay.
And dry just means they have less of that fluid congestion.
Okay, so wet is like the faucet's running, and dry is it's more controlled.
Yeah, I like that.
Okay.
Now, the warm part, that means they have good blood flow to their extremities.
Okay.
You'll feel a nice, strong pulse. Their skin will be warm.
Okay.
But if they're cold, that means they have poor perfusion.
Okay.
So their extremities might be cool or clammy. The pulse might be weak.
Interesting. And I remember you mentioned that even like gut problems can be a sign of ADHF.
It's all about blood flow, remember?
Right.
When that heart's not pumping well,
yeah,
the gut can suffer too.
Okay.
So you might see nausea, vomiting, especially after eating, even abdominal pain, because the blood flow to the intestines isn't so good.
So it's like a whole body problem.
Your whole system is affected.
So they don't always fit neatly into those boxes, right?
Right. Those are just categories.
Okay.
There could be a lot of overlap.
Makes sense.
And patients can even shift between those profiles as their condition changes.
Okay, interesting. So we have someone coming in, they're short of breath.
Okay.
How do we diagnose ADHF? Is there a specific test?
You wish it were that simple.
Right.
Unfortunately, there's no one test that says, yep, this is definitely ADHF.
Yeah.
Dyspnea, that shortness of breath, is a big clue, but lots of things can cause that, right?
Right. Pneumonia, a blood clot.
Anxiety even.
So you have to use your clinical judgment.
Absolutely. You got to look at the whole picture.
Okay, so what about BNP? Can that help?
BNP can be really helpful, but it's not perfect.
Yeah.
If it's low, it makes ADHF less likely.
Okay.
But it can be high for other reasons, too.
Like what?
Kidney problems, pulmonary embolism, even sepsis.
So again, it's a piece of the puzzle.
Exactly. Got to connect the dots.
And the review guide mentioned these pulmonary artery catheters, or PACs.
Yeah, PAC.
Do those play a role in diagnosis?
They can be helpful in certain cases.
Okay.
But we don't use them for every ADHF patient. Okay. They can give us really detailed information about the pressures inside the heart and lungs.
Okay.
Which can help us fine-tune treatment, especially with fluids.
Got it. But I remember reading that they don't necessarily improve outcomes.
Yeah, they're not a magic bullet.
Right.
We use them in specific situations.
Okay.
Like if someone isn't responding to initial treatment.
Okay.
Or if we're really unsure about their fluid status, even after doing an exam and other tests.
So they're a tool, but not the first one you reach for.
Right. It depends on the situation.
All right, so let's switch gears a bit.
Okay.
Let's say we have our diagnosis.
Okay.
We know it's ADHF.
Right.
What do we do to treat it? How do we stabilize these patients?
All right, well, this is where things get really interesting.
Okay.
And where your pharmacy knowledge is going to shine.
All right, love to hear that.
It's a multi-pronged approach, and it all starts with taking a good look at their current meds.
So we're talking about their chronic heart failure medications, right?
Exactly.
Yeah.
ACE inhibitors, beta blockers, that kind of thing.
Yep.
Those are important for the long haul. But in the acute setting, we might need to adjust things.
Okay.
Maybe change the doses or even hold certain meds for a bit.
So it's not just a cookie-cutter approach.
Absolutely not. Every patient's different.
Right.
For instance, if their blood pressure is really low, we might need to reduce or even stop those meds that lower blood pressure, like beta blockers.
Okay, that makes sense.
And if their kidneys are having a hard time, we got to be careful with meds that are cleared by the kidneys, like ACE inhibitors.
You don't want to make things worse.
Nope, got to protect those kidneys.
So it's all about individualizing treatment.
Exactly. Now, another key part of our plan often involves tackling that fluid overload.
Okay, so what's the strategy there?
We bring in the big guns, IV diuretics.
Diuretics, okay.
Those are our workhorses for getting rid of that extra fluid.
So like little plumbers working in the kidneys.
Yeah, I like that visual, flushing out all that excess fluid.
Okay, so how do they actually work?
Think of the nephron, the functional unit of the kidney, like a series of pipes.
Okay.
Diuretics work by targeting different parts of those pipes, essentially blocking the reabsorption of sodium and chloride.
And that makes them pee more.
Exactly. It creates an osmotic gradient, pulling water into the urine, increasing urine output, and getting rid of that fluid overload.
So they're making those kidneys work overtime.
You could say that. But are all diuretics the same?
That's a good question. I'm assuming the answer is no.
You got it. For 5E administration in ADHF, furosemide and bumetanide are our go-tos.
Okay.
Those are loop diuretics. They work in the loop of Henle, a specific part of the nephron.
Gotcha. Loop diuretics.
They're equally effective IV at equivalent doses.
Okay.
Now, we also have torsemide, but that's only available orally, so not ideal for the acute setting.
Okay, so IV furosemide or bumetanide for these acutely ill patients.
Right.
But with any potent medication, especially one that affects fluid and electrolytes, monitoring is key, right?
Absolutely. It's all about careful monitoring.
What are we watching for specifically?
We're checking those vital signs like a hawk, especially blood pressure.
Okay.
Because losing fluid too fast can cause it to tank.
That makes sense.
We're also tracking fluid input and output, checking daily weights, and keeping a very close eye on those electrolytes.
Electrolytes, why are those so important?
Well, electrolytes are crucial for maintaining the heart's rhythm.
Okay.
When those levels get out of whack,
Yeah.
it can lead to arrhythmias, irregular heartbeats.
Oh, okay.
Which can be dangerous, especially when the heart's already struggling.
So we're walking a tightrope, it sounds like.
You could say that. It's a balancing act.
All right, so we're monitoring, we're adjusting. But what if those diuretics aren't enough?
Good question. We've got some tricks up our sleeve.
Okay, like what?
We might think about adding a thiazide-type diuretic, like metolazone,
Okay.
or even IV chlorothiazide.
Okay.
They work in a different part of the nephron.
Okay.
So they can team up with those loop diuretics and really enhance that fluid removal.
So it's a team effort.
You got it. Sometimes you need reinforcements.
Are there any other options if those aren't cutting it?
We do have another diuretic, acetazolamide, that works in yet another part of the nephron, the proximal tubule, provides a different mechanism of diuresis, and can be helpful in some cases.
Okay.
We could also think about giving the loop diuretic as a continuous infusion instead of those intermittent doses.
Interesting. So we've got lots of different diuretics to choose from.
We've got options.
Okay, great. But what if we've optimized the diuretics and things still aren't looking good?
Well, if their blood pressure allows and they're still congested even with the diuretics, we might consider adding IV vasodilators to the mix.
Vasodilators, like opening up the floodgates.
Yeah, that's a good way to think about it.
Okay.
They relax the blood vessels and ease that pressure on the heart.
So how do they actually work in ADHF?
Okay, so by widening those blood vessels, vasodilators can do a few helpful things. First, they can help with that pulmonary congestion, that shortness of breath from fluid in the lungs.
Right.
They do this by increasing venous capacity, so the veins can hold more blood.
Okay.
And by lowering venous pressures, which reduces the pressure pushing fluid into the lungs.
Just like taking the pressure off the whole system.
Exactly. Plus, they can help with cardiac output and kidney function.
Oh, wow. How's that?
So by decreasing systemic vascular resistance, that's the overall resistance the heart has to pump against.
Right.
Vasodilators can actually help the heart pump better.
Okay.
Which improves blood flow to all the vital organs, including those kidneys.
And that better blood flow to the kidneys helps them filter better and get rid of more fluids.
You got it. It's all connected.
So which vasodilators do we use in ADHF?
The two main ones are nitroglycerin and nitroprusside.
Okay, let's start with nitroglycerin. I know it's used for angina too, but what about ADHF?
So nitroglycerin is what we call a nitric oxide donor, meaning it releases nitric oxide in the body. And nitric oxide is a potent vasodilator, so it tells those blood vessels to chill out and widen.
Got it. So it's all about relaxation.
Exactly. Now, nitroglycerin mainly affects preload.
Preload, right, the blood coming back to the heart.
You remember.
Yeah.
So by dilating those veins, it reduces the amount of blood going back to the heart, which gives the heart a break.
Sounds like a win-win. Are there any downsides?
Well, like most meds, it has its quirks. Nitroglycerin can cause headaches, which makes sense given its effect on blood vessels.
Right.
And if you use it for too long, patients can develop tolerance, meaning they need higher doses to get the same effect.
So you have to be careful with it.
Always.
Now, what about nitroprusside? How's that one different?
Nitroprusside is also a nitric oxide donor, but it's a bit more potent.
Okay.
And it affects both preload, AD, afterload.
Oh, wow. A double whammy?
You could say that. It can be really effective in lowering those pulmonary artery pressures and that systemic vascular resistance.
So it really takes the pressure off.
It does, but with great power comes great responsibility, right?
Meaning?
Nitroprusside gets metabolized to cyanide in the body.
Cyanide, isn't that, like, dangerous?
It can be if it builds up, especially in folks with liver or kidney problems.
Okay.
That's why we monitor these patients super closely.
Yeah.
And we try to avoid using high doses for a long time.
Right.
And if we need to, we'll consider other options.
So nitroprusside is a powerful tool, but you gotta be careful.
Exactly. Safety first.
We've talked about diuretics and vasodilators, two big strategies for managing fluid overload and helping the heart.
Right.
But what if we've tried all that and the heart is still struggling to pump?
Well, in those cases, we might need to call in the cardiac cheerleaders the inotropes.
Inotropes, those are like giving the heart a pep talk, right?
That's a good way to put it. They increase the force of the heart's contractions.
So they're like a temporary support system.
Yeah, they help the heart keep up while we try to fix the underlying problem.
Okay, which ones do we talk about here?
For use in ADHF, the main players are dobutamine and milrinone.
Okay, dobutamine and milrinone. Let's break those down.
Sure.
Starting with dobutamine, how does it work?
Dobutamine is a beta-adrenergic agonist.
Okay.
Think of it as adrenaline for the heart.
Okay.
It stimulates those beta receptors in the heart muscle.
Okay.
And that leads to increased contractility, so each heartbeat is stronger.
So it's giving the heart a boost.
Exactly, giving it a little extra oomph.
And milrinone, how's that one different?
Milrinone takes a different approach. It's a phosphodiesterase 3 inhibitor,
Okay.
or PDE3 inhibitor for short.
Okay.
It works by increasing the levels of this molecule called cyclic AMP inside the heart cells.
Cyclic AMP, what does that do?
So cyclic AMP is really important for the heart's contraction process.
Okay.
By increasing its levels, milrinone basically enhances the heart's ability to squeeze.
So stronger heartbeat.
A stronger heartbeat, exactly.
So both dobutamine and milrinone help the heart pump better?
They do, but like any powerful medication, there are some things to watch out for. What kind of things?
One thing to keep in mind is that they can cause arrhythmias, those irregular heartbeats.
Okay, so we need to monitor their heart rhythm closely.
Always. And with milrinone, we need to be extra cautious in patients with kidney problems.
Okay.
Because it can build up and cause hypotension or low blood pressure.
Gotcha. So powerful medications, but you got to be careful.
Always weighing the risks and benefits.
So are these inotropes a long-term solution for ADHF?
They're more like a bridge, a temporary measure to stabilize the patient.
Okay.
They give the heart a boost while we try to address the underlying causes of the heart failure.
So it's like the cavalry coming in to save the day.
Yeah, a good analogy.
But they're not meant to stay forever.
Exactly. In the long run, it's those other strategies, like optimizing their chronic medications, addressing lifestyle factors, maybe even considering more advanced things like mechanical support devices or heart transplant.
Right.
Those are the things that will really make a difference in the long term.
So it's a multi-pronged approach.
Wow, we've covered a lot already. The pathophysiology, the meds.
It's a lot to take in.
It's clear that managing ADHF really requires a deep understanding of the disease and the medications.
You can't just memorize drug names and doses.
Right.
You really have to understand how they work, the potential benefits and risks, and how to personalize treatment for each patient.
And that's where our expertise as pharmacists comes in, right?
Absolutely. We're the medication experts.
Okay, so we focused a lot on medications.
Yeah.
But you mentioned these other things like mechanical support devices and heart transplants.
Those are definitely worth talking about.
They sound kind of sci-fi to me.
Maybe, but they can be life-saving for some patients.
Wow, okay. So we'll definitely explore those more next time.
Definitely. And we'll talk about that transition from the hospital to home and how to set our patients up for success.
Sounds good. Looking forward to it.
Me too.
All right, so stay tuned, everyone. We'll be back soon to continue our deep dive into ADHF.
See you then.
Welcome back to our deep dive into acute decompensated heart failure.
You got it.
We've been talking about all sorts of things, physiology, the medications.
All the fun stuff.
Exactly. But now I want to talk about something that's maybe a little more high-tech.
Okay.
You mentioned things like mechanical support devices and even heart transplants.
Right.
It sounds a little futuristic to me.
It does sound like something out of a movie, but this is real stuff, and it's making a huge difference for patients with advanced heart failure.
Okay, so when meds aren't enough, these devices can help the heart keep going.
They step in and provide that extra support.
Okay, let's start with the mechanical support devices.
Okay.
What are we talking about here specifically?
So we're talking about devices that basically help the heart pump blood when it's too weak to do it on its own.
So they're like a mechanical partner for the heart.
Yeah, exactly. They share the workload.
Okay, so what kind of devices are out there?
Well, there are a few different types,
Sure.
each with its own mechanism and purpose.
Okay.
Let's start with the intra-aortic balloon pump, or IABP for short.
IABP, that sounds intense.
Yeah. It's a bit of a mouthful.
Where does it even go?
So it's a catheter with a balloon on the end.
Okay.
And it gets inserted into the aorta.
The aorta, so that's like the main artery coming out of the heart.
Exactly. The one that carries all that oxygen-rich blood to the body.
Okay, so the balloon's in the aorta, what does it do?
So the balloon inflates and deflates in sync with the heartbeat.
Okay.
That synchronized action is really important.
Okay.
So when the heart contracts, the balloon deflates.
Okay.
And that creates sort of a vacuum effect.
Okay.
That helps pull blood out of the left ventricle and into the aorta.
So it's helping the heart pump the blood out.
Exactly. It's giving it an assist.
And when the heart relaxes, what happens?
Then the balloon inflates.
Okay.
And that gently pushes blood back towards the coronary arteries.
Coronary arteries, so the ones that feed the heart muscle itself?
Exactly. So it's helping with both the forward flow of blood to the body.
Okay.
And the blood flow back to the heart muscle.
So it's like a 2-for-1 deal.
You got it. It's pretty ingenious.
So when would you use an IABP?
They're often used as a short-term support measure.
Okay.
Especially in critical situations like cardiogenic shock.
Cardiogenic shock, that sounds really serious.
It is. It's basically when the heart's pumping ability is so bad that it can't meet the body's needs.
Oh, wow.
So the IABP helps stabilize the patient, gives the heart a chance to rest, and hopefully recover.
Okay, so it's like buying time.
Exactly, a bridge to recovery.
So what if the heart needs more than just a temporary boost?
Right. So in those cases, we might consider a left ventricular assist device, or LVAD.
An LVAD?
Yeah, they're a bigger commitment than an IABP for sure.
Okay.
But they can really change the game for people with advanced heart failure.
All right, so what is an LVAD exactly? How does it work?
An LVAD is a surgically implanted pump. That takes over a lot of the left ventricle's job, pumping blood to the body.
So it's basically like a mechanical heart.
Yeah, in a way, it's constantly pulling blood from the left ventricle and pushing it into the aorta.
Wow, so it's like a permanent helper for the heart.
It can be. For people with end-stage heart failure who aren't eligible for a heart transplant, an LVAD can be a long-term solution.
Really?
It improves their quality of life and helps them live longer.
That's amazing. It's like a true partnership with the heart.
Exactly, sharing the workload.
Now, you mentioned that an LVAD could also be a bridge to transplant.
Right.
So for someone who's waiting for a donor heart.
Yeah, it can help them stay alive and healthy while they wait.
Wow. So speaking of heart transplants, let's talk about that.
Okay.
It's a major procedure, but it can save lives.
Absolutely. It's the ultimate treatment for end-stage heart failure.
So you're replacing the failing heart with a healthy one.
Yeah. It's pretty incredible when you think about it.
It really is.
Yeah.
But I'm sure it's not a decision that's made lightly.
No, not at all. It's a very complex decision.
What goes into deciding if someone's a good candidate?
We look at their overall health, their age, their lifestyle, their social support system.
Okay.
We want to make sure they're physically and mentally ready for a transplant.
Yeah.
And that they have the support they need to recover and manage all the changes that come with a transplant.
Right, because it's not just the surgery itself, it's a whole new way of life.
Exactly. It's a big commitment.
What are some of the challenges that people face after a heart transplant?
Well, one of the biggest ones is rejection.
Rejection meaning?
The body's immune system sees the new heart as a foreign invader.
So it tries to attack it.
Yeah, unfortunately. That's why people have to take immunosuppressant medications for the rest of their lives.
Okay, to suppress the immune system.
Right. It helps reduce the risk of rejection.
But that also makes them more susceptible to infections.
Right. It does. So it's a delicate balance.
Yeah, I can see that.
We want to prevent rejection, but we also want to minimize the risk of infections.
So it's like walking a tightrope.
Exactly. And there are other challenges too.
Like what?
Well, the immunosuppressant medications can have side effects.
Okay.
Some are mild, but some can be more serious.
Right.
And then there's the emotional and psychological adjustment.
Yeah, that must be tough.
It can be. It takes time to adapt to living with a transplanted heart.
Because a whole new life.
It is. But for many people, it gives them a second chance.
A chance to do things they couldn't do before.
Exactly. To live a fuller life.
That's really powerful.
It is.
Okay, so we've talked about these incredible interventions.
Yeah.
IABPs, LVADs, heart transplants.
It's amazing technology.
But I'm also thinking about prevention.
Prevention is always key.
What can people do to lower their risk of developing heart failure in the first place?
So much of it comes down to lifestyle.
Okay, so what kind of lifestyle changes are we talking about?
The big ones are diet and exercise.
Okay, the usual suspects.
Yeah, but they're important for a reason. A heart-healthy diet is crucial.
Okay, so what does that look like?
Low in sodium, saturated fat, and processed foods.
All right.
And plenty of fruits, vegetables, whole grains, lean protein.
Got it. So basically, a balanced and healthy diet.
Exactly. And then there's exercise.
Right, and getting that heart pumping.
It's like medicine for the heart.
Okay, what about smoking?
Smoking is a huge no-no for heart health.
Yeah. I figured as much.
It damages blood vessels, raises blood pressure.
Increases the risk of heart attack, stroke.
All of the above. Quitting smoking is one of the best things you can do for your heart.
I think we all know someone who needs to hear that.
Probably. And remember, it's not just about quitting yourself.
Right.
You also want to avoid secondhand smoke.
Because it's just as harmful, right?
Exactly. It's all about protecting those blood vessels.
Okay, so diet, exercise, smoking cessation, any other lifestyle factors to keep in mind?
It's also really important to manage other health conditions.
Okay, like what?
Things like high blood pressure, diabetes, high cholesterol.
Right, those can all affect the heart.
Exactly. If they're not controlled, they put extra strain on the heart and increase the risk of heart failure.
So it's a whole body approach.
You got it. Taking care of your whole self.
Okay, so we've talked about these amazing interventions and the importance of prevention.
Right.
But now I'm thinking about that transition from the hospital to home.
That's a critical piece of the puzzle.
It is. We've stabilized the patient in the hospital.
Yeah.
But how do we help them stay healthy once they're back home?
That's where our skills as pharmacists really come into play.
Okay, I like where this is going.
We need to make sure our patients have the knowledge, the tools, and the support they need to thrive.
It's like sending them off with a map and a compass.
Yeah, I like that analogy.
To help them navigate life with this chronic condition.
Exactly. And that map includes several key landmarks.
Like what?
First and foremost, we need to optimize their medication regimen.
Okay, so making sure they're on the right meds at the right doses.
Exactly. To keep those symptoms under control and prevent future hospitalizations.
So we're talking about those guideline-directed medical therapies for heart failure.
Yes. The ACCHA guidelines are our roadmap here.
Okay.
They provide a framework for evidence-based prescribing.
And they emphasize the importance of assessing ejection fraction, right?
Exactly. The EF tells us how well the heart is pumping.
Right, like a gauge showing how much blood the heart is ejecting with each beat.
And if the patient has heart failure with reduced ejection fraction, or HFrEF,
HFrEF.
where that pumping power is really low,
Okay.
the guidelines recommend certain medications that have been proven to improve outcomes.
Okay, so let's talk about those medication recommendations.
Okay.
I remember from pharmacology that ACE inhibitors are really important for HFrEF.
They're a cornerstone of treatment.
So how do they work?
ACE inhibitors block the production of angiotensin II.
Angiotensin II.
Which is a powerful hormone that makes blood vessels constrict.
So they're preventing that constriction.
Exactly. By inhibiting angiotensin II, ACE inhibitors help relax those blood vessels, lower blood pressure, and reduce the workload on the heart.
It's like taking the pressure off.
Yeah, giving the heart a break.
And then we have ARBs. Right.
Right, angiotensin II receptor blockers.
They also block the effects of angiotensin II.
They do, but instead of inhibiting its production, they block its action at the receptor level.
Okay, so it's like shutting down the communication line.
Exactly, preventing those blood vessels from constricting.
So both ACE inhibitors and ARBs have the same goal.
They do. They're both working to relax those blood vessels and make it easier for the heart to pump.
Okay, I'm with you. Now, what about these ARNIs I've been hearing about?
ARNIs, those are a newer class of drugs.
Yeah, I don't remember learning about them in pharmacy school.
They're relatively new and they're pretty exciting.
Okay, how so?
ARNIs combine the benefits of an ARB with a neprilysin inhibitor.
Neprilysin inhibitor. Remind me what neprilysin does again.
Sure. Neprilysin is an enzyme that breaks down natriuretic peptides.
Right, like BNP.
Exactly. So by inhibiting neprilysin, we're actually boosting the levels of those beneficial natriuretic peptides.
Okay.
Allowing them to do their job of relaxing blood vessels and getting rid of fluid.
So it's like a 2-for-1 deal again?
You could say that. It's a powerful combination.
And they've been shown to be effective.
The clinical trials have been very impressive.
Okay, so ARNIs are definitely on the map now.
They are.
What about beta blockers? I remember being taught that they were bad for heart failure.
Yeah, that was the thinking for a long time.
Because they can weaken the heart's contractions, right?
Right. They have that initial negative inotropic effect.
But now we know that's not the whole story.
Exactly. Research has shown that beta blockers can actually improve long-term outcomes in heart failure.
Really? Even though they initially weaken the heart?
It seems counterintuitive, but it's true.
Okay, how does that work?
So beta blockers block the effects of adrenaline on the heart.
Okay.
And adrenaline, while it's helpful in fight-or-flight situations, it's not so good for a failing heart.
Okay.
It makes the heart work harder and faster, which can lead to more damage.
So it's like putting the brakes on the heart.
Exactly. By slowing the heart rate and reducing the force of contractions.
Oh?
Beta blockers give the heart a chance to rest and recover.
So it's like a long-term strategy.
It is. It's about protecting the heart from overexertion.
Okay, that makes sense. But I'm guessing you have to be careful with beta blockers in these patients.
Absolutely. We start low and go slow.
Okay.
Gradually increasing the dose as the patient tolerates it.
And monitoring closely?
Always. We're watching for any signs that the heart failure is getting worse.
So it's all about finding that right balance.
Exactly. The dose that provides the benefits without pushing the heart too far.
All right, so we've got ACE inhibitors, ARBs, ARNIs, beta blockers.
4 big players in the HFrEF game plan.
Any other medications that might be part of the mix?
Yeah, there are a couple more to consider.
Like what?
Aldosterone antagonists like spironolactone.
Aldosterone antagonists, okay.
They're especially helpful for patients with more severe heart failure.
Okay, how do they work?
They block the action of aldosterone.
Aldosterone, okay.
Which is a hormone that promotes sodium and water retention.
Ah, so they're helping with fluid overload again?
Exactly. By blocking aldosterone, these medications help the body get rid of excess fluid, which reduces congestion and eases the strain on the heart.
So they're like another tool in our fluid-fighting arsenal.
Exactly. And then we have a couple of other options that we might consider depending on the patient's individual needs.
Okay, like what?
Digoxin is an older medication.
Yeah, I remember digoxin.
It can help strengthen the heart's contractions.
Okay.
And we sometimes use it in patients who still have symptoms despite taking all those other medications we talked about.
And what about that combination of hydralazine and isosorbide dinitrate?
That's a good one to remember.
Okay.
Hydralazine is a vasodilator, and isosorbide dinitrate is a nitrate that also has vasodilating effects. This combination can be particularly helpful in African American patients who haven't responded to other therapies.
Wow, so many different options.
We've got a lot of tools in our toolbox.
It's clear that finding the right medication regimen is really complex.
It's a process.
And it really highlights the expertise of pharmacists.
Absolutely. We're the ones who understand the nuances of each medication.
Right. It's not just about memorizing names and doses.
No, it's about understanding how they work, their potential interactions, and tailoring therapy to each patient's individual needs.
Okay, so we've talked about the medications, but there's more to it than that, right?
Absolutely. Patient education is crucial.
Especially when they're transitioning from the hospital to home.
Exactly. It's a big adjustment for them.
I can imagine.
New medications, lifestyle changes, a chronic condition to manage.
It must feel overwhelming.
It can be. And that's where we as pharmacists can make a huge difference.
Okay, so how do we help them?
We need to empower them with knowledge. Give them the tools to manage their medications effectively.
Okay.
And answer their questions honestly and thoroughly.
So it's not just about handing them a bag of pills and saying good luck.
No, it's about being there for them, guiding them through the process.
So what kind of things should we be explaining to them?
Well, we need to explain how those medications work, what side effects to watch out for, and how to take them correctly.
Right, making sure they understand their medication regimen.
Exactly. And we need to provide guidance on those lifestyle modifications we talked about earlier.
Okay, the diet, exercise, smoking cessation.
All of that. It all plays a role in preventing those acute decompensated episodes and keeping the heart healthy.
And what about social support?
Social support is so important.
Family, friends.
Exactly. They can provide encouragement, practical help, and just a listening ear.
It takes a village, right?
It really does. And of course, we need to stress the importance of regular follow-up appointments.
Okay.
With their doctor, their cardiologist.
To monitor their progress, make adjustments to their treatment plan.
Exactly. It's an ongoing process.
Right, so it's a team effort.
Absolutely. The patient, their loved ones, their healthcare providers.
We're all in this together.
We are.
Well, we've covered a lot of ground in this deep dive into acute decompensated heart failure.
We have. From the hospital to home and everything in between.
I hope our listeners are feeling more confident in their understanding of this condition.
I hope so. It's a complex topic, but it's so important for pharmacists to understand.
We've talked about the pathophysiology, the medications, the lifestyle modifications, the importance of patient education and support.
All connected.
As we wrap up this section of our deep dive, what's the one message you want our listeners to take away?
That ADHF is serious, but it's manageable with the right treatment, lifestyle changes, and a supportive healthcare team.
Yeah.
Patients can live full and meaningful lives.
That's a message of hope.
It is. There's always hope.
All right, so stay tuned for the final part of our deep dive, where we'll explore that transition from acute care to chronic management in more detail.
All right, going to be good.
We'll see you then. All right, welcome back to our final deep dive into acute decompensated heart failure.
We've explored the pathophysiology, those powerful medications.
The high-tech interventions.
And now we're at that crucial point, that transition from acute care in the hospital to managing heart failure long-term at home.
Right, because it's one thing to stabilize someone in the hospital, but then how do we set them up for success once they go home?
It's a whole other ballgame, right? It's where our skills as pharmacists really shine.
Yeah, I agree.
We got to equip them with the knowledge and tools to manage this condition and really thrive despite the challenges.
It's almost like, giving them a map and compass.
Yeah, a good way to think about it.
To navigate this new terrain of living with a chronic illness.
And there are some key landmarks on that map.
Okay, like what?
First, optimizing their medications.
Yeah. Okay, so making sure they're on the right meds, the right doses.
Exactly. To keep those symptoms under control and prevent them from landing back in the hospital.
So we're talking about those guideline-directed medical therapies.
You got it. Those evidence-based recommendations from the ACC and AHA. Those are our guiding principles.
And I remember they really stressed the importance of assessing ejection fraction.
Right, the EF.
Which is basically, how well the heart is pumping.
Exactly, like a gauge showing how much blood the heart ejects with each beat.
Okay, and if someone has heart failure with reduced ejection fraction, HFrEF, there are certain meds that are recommended.
Exactly. Medications that have been shown to improve outcomes.
Okay, so let's dig into those recommendations.
Okay.
I remember from pharmacology that ACE inhibitors are a big deal for HFrEF.
Absolutely, a cornerstone of treatment.
So how do they work their magic?
ACE inhibitors block the production of angiotensin II, which is this powerful hormone that makes blood vessels constrict. So by blocking angiotensin II, ACE inhibitors help relax those blood vessels, lower blood pressure, and ease the workload on the heart.
So less stress on the heart.
Exactly, giving it a much-needed break.
And we also have ARBs, right?
Right, angiotensin II receptor blockers.
They also block the effects of angiotensin II, but in a different way, right?
Yeah. Instead of inhibiting its production, they block it at the receptor level.
So it's like cutting off communication.
Exactly, preventing those blood vessels from constricting.
Okay, so both AC inhibitors and ARBs, same goal.
Same goal, different mechanisms.
Now, what about these ARNIs I keep hearing about?
ARNIs, yeah, those are an exciting newer class of drugs.
I feel like they weren't even on the radar when I was in school.
They're relatively new, and they're making waves.
Okay, what makes them so special?
They combine the benefits of an ARB with a neprilysin inhibitor.
Okay, neprilysin inhibitor.
Right.
Can you remind me what neprilysin does again?
Sure. Neprilysin is an enzyme that breaks down those helpful natriuretic peptides.
Oh, right, like BNP, just like the heart's distress signal.
Exactly. So by inhibiting neprilysin, we're actually boosting the levels of those good guys.
Interesting.
Letting them do their job of relaxing blood vessels and getting rid of fluid.
So it's like a double win.
You got it. And the clinical trials have shown some really impressive results.
Okay, sounds like ARNIs are here to stay.
They are.
Now, beta blockers.
Yeah.
I remember being taught that they were bad for heart failure.
Right, because they can weaken the heart's contractions.
But now we know that it's not that simple.
Nope.
They can actually help in the long run.
They can. It seems counterintuitive.
It does.
But research has shown that beta blockers can improve outcomes.
Okay, so how does that work?
They block the effects of adrenaline on the heart.
Adrenaline, okay.
Which, it's good for fight or flight, but not so good for a heart that's already struggling.
Right, makes it work too hard.
Exactly. Makes it pump harder and faster, which can lead to more damage.
So beta blockers are kind of like calming things down.
Yeah, like putting a gentle brake on the heart.
So it can rest and recover.
Exactly. And in the long run, that can actually strengthen the heart.
Interesting.
But we have to be careful with them.
Of course.
Start low, go slow, watch for any signs of trouble.
So finding that right dose is key.
Absolutely. The dose that gives you the benefits without pushing the heart too far.
All right, so we've got ACE inhibitors, ARBs, ARNIs, beta blockers, all playing a role.
The A team for HFrEF.
What else might we consider?
Aldosterone antagonists like spironolactone.
Aldosterone antagonists, okay.
They're especially helpful in patients with more severe heart failure.
Okay, remind me how they work.
They block the action of aldosterone, a hormone that makes you hold on to sodium and water.
So it's all about fighting fluid overload again.
Exactly. Getting rid of that excess fluid to reduce congestion and make it easier for the heart to pump.
Okay, so we've got a lot of different medications we can use.
We do.
And finding the right combination for each patient is like an art form.
It is. It takes a lot of knowledge and skill.
And that's where pharmacists shine, right?
Absolutely. We're the medication experts.
Okay, so we've talked about the meds, but there's more to it than just that, right?
Right. We can't just hand them a bag of pills and say, see you later.
Exactly. Patient education is huge.
It is.
Especially when they're transitioning from the hospital to home.
Yeah, it can be really overwhelming for them.
I can imagine. New medications, lifestyle changes, a chronic condition to manage.
It's a lot to process.
So what can we do as pharmacists to help them through this?
We got to empower them with knowledge.
Okay.
Give them the tools to manage their medications effectively, answer their questions, be there for them.
So it's like being a guide, a resource.
Exactly.
What kind of things should we be explaining to them?
We need to explain how the medications work, what side effects to watch out for, how to take them correctly.
Make sure they really understand their medication regimen.
Exactly. And we need to provide guidance on those lifestyle changes too.
The diet, exercise, smoking cessation.
All of it. It all plays a role in preventing those acute episodes and keeping that heart healthy.
And what about support systems?
Oh, social support is crucial.
Family, friends.
Yeah, they can provide so much encouragement, help with practical things, and just a listening ear.
It's true. Having a support system can make a big difference.
It can, and we also need to emphasize the importance of follow-up appointments.
Okay, so they're staying connected with their healthcare team.
Exactly. Regular checkups to monitor their progress, make any adjustments to the treatment plan.
It's an ongoing process.
It is a partnership between the patient, their loved ones, and their healthcare team.
Well said. We've covered a lot of ground in this deep dive into ADHF.
We have, from the initial presentation to long-term management.
It's a complex condition, but hopefully our listeners have a better understanding now.
I hope so. It's an important topic for pharmacists.
We've talked about the medications, the lifestyle changes, the importance of patient education and support.
It's all connected. Every piece matters.
So as we wrap up this final part, what's the key takeaway message you want to leave our listeners with?
ADHF is serious, but it's manageable. With the right treatment, the right lifestyle changes, and a strong support system.
Yeah.
People with ADHF can live full and meaningful lives.
That's a powerful message. Thanks for joining us on this deep dive into acute decompensated heart failure. Until next time, keep learning and keep making a difference for your patients.